talk on ECMO for interventional cardiologists. So I'll talk a little bit on ECMO, how to do circuits, and then a couple of cases, and then we'll close with that and we'll do some discussion. Indication for emergency ECMO. Any hemodynamic compromise that is unlikely to be transient is best and can't be managed with drugs efficiently. To me, ECMO is what we go for. Of course, once the crash happens, IABPs and drugs are unlikely. You need quick pump support or good CPR plus drugs sometimes also helps. You don't always need ECMO. And of course, CPR and out-of-hospital cardiac arrest, which is obvious. But more specifically for cardiologists, this is the main indication for elective ECMO, which is current interventions requiring pump support. Obviously, we need a clean LV offloading system, which will be impeller, but then because of cost constraints, it may not always be possible, and units may not have expertise in that. VT-VF ablation during requiring pump support, you can do not only substrate ablation, but also do activation mapping, which we use that quite often. And structural heart interventions, I think with high-risk TAVR, or TAVRs, or lampoons, or transvenous transseptal TAVRs, this have been extremely helpful. Endovascular interventions, again, selected cases we can use ECMO, especially for brain perfusion, for arch perfusion from subclavians. Types of ECMO, you're all familiar. VA ECMO, mainly cardiopulmonary support. Veno-venous is just pulmonary support, no pump support, just oxygenation. ECMO strategies, the various ways of cannulating, I wouldn't go into this. This is an exhaustive slide. But the setup, I think this is important. What are the disposables and what are the equipment that one requires? Not many centers in the country are equipped with ECMO. So this is a useful slide just to know what are the basic disposables and equipments one requires to have an ECMO service available. VA ECMO, of course, supports the heart and the lung. That requires two large bore cannulas, one in the vein and the artery, and the cannulation you can do, of course, from the top or from the bottom, but the preferred is from the femoral, both V and the A cannulas. One has to remember this is not a cardiopulmonary bypass circuit because there is no vent, i.e. there is no venous reservoir. So therefore, offloading the LV may not be very effective if you want to run the ECMO for much longer periods and if the LV starts distending. But for peri-procedural PCI support, for TAVR, very easy. We do this all the time, and it is done interventionally, and we don't involve surgery. It's not necessary. It's a percutaneous procedure. The initial ECMOs are where like this, very, very cumbersome, scary. You don't know what's going where, but this is not the case anymore. It's very, very sleek. But the downside is ECMO and hemodynamic machine management like this is not part of the curriculum for cardiologists unless you go through specific training. So we will go through that towards the end of the case, but very, very straightforward if you go through a specific and short training. This is the circuit. I think you're all familiar with the circuit. The blood comes out, gets oxygenated, gets pumped into the artery. We always do a fem-fem, which is the most convenient location for cardiologists and has the widest bore vessels for that. The cannulas, there are various size cannulas. This is largely based on the patient weight. But on a ballpark figure, any 70 kilogram man, you only need a 24 venous and a 17 arterial. That's all you need. This is a picture from an ECMO circuit established patient. You can see here two large bore cannulas. The cannula that here, if you can see my cursor, which is marked red, is the arterial inflow where the blood goes in. From here, you have a slave cannula that here is also perfusing a tiny 6 French. What the 6 French is doing, this is ipsilateral leg perfusion, because when you put an arterial cannula that big, you will lose perfusion to the leg. And if your procedure is going to be beyond 6 hours or 7 hours, or perhaps you need pump support for more than 6 hours, 7 hours, it is wise to always get an ipsilateral leg perfusion cannula where a little bit of blood is going down. Otherwise, you're at risk of having an ischemic leg and your lactate will go up, and then you might end up with amputation. The other cannula, which is here, the venous cannula, which is marked blue, is the venous return cannula that comes from the RA that goes straight to the pump. So this is roughly the setup, and once you get the hang of it, it's very, very easy to establish ECMO. Usually takes about 4 to 5 minutes in a CSENS unit with CSEN teams. The flow requirements, I won't go into this. This is very exhaustive. This is from the course, but I won't bore you with all this. Again, cannula, I won't go into this, but preparation. ECMO is not just an equipment you stick it in, like impeller. Impeller is very easy. You don't need a big team and a skilled interventional cardiologist in the console and you put it in. That's it. But for ECMO, it's not like that. You need skilled personnel. You need people trained in ECMO. You need a good perfusion unit. You need a runner perfusionist. You need a lot of other equipment such as blood products, cannulas, the console, and facilities with an ECMO ICU in the same hospital, which will be very useful. Weaning and decannulation, usually we do it with echo support as long as the LV is contracting and we're meeting hemodynamics with 0.5 flow on the ECMO and the PA pressures are okay. We will come off ECMO on the cath lab table. So the patient also ECMO on the cath lab table, usually very procedural support, it comes off on the cath lab table, very rarely onto the CCU. This is, let me give you a quick example. This is a patient who we all agree has very poor LV function, had critical stenosis, was in pulmonary edema, cardiogenic shock, and you can see the aortic valve critically narrowed. The CT scan, which was done way before this admission, showed clearly a bicuspid valve. So you straight away know you're going to involve a lot of pre-dilatation, perhaps post-dilatation also. And to make things worse, this patient was completely graft dependent. So straight away, you know, if you stop the heart for any long period of time, especially with that LV, with a graft dependent circulation, they may never come out. And this patient, we went on VA ECMO. You can see here venous cannula placed. And then once VA ECMO is on standby, we did pre-dilatation. And as soon as we pre-dilated, the LV crashed, but the pump was already ready, set, was on 0.5 flow. We just went on full flow and we had complete hemodynamic stability. Once hemodynamic stability was achieved, we put a valve in, of course, was not well expanded. We then post-dilated it because you had all the time, you had paddle pump support. So you can optimize the valve well, and then the patient, the ECMO was removed in the cath lab table, and now it's 5 years from the time of the procedure, and the patient does very well in NVH class 1. And this is him. This is the pre-procedural echoes there on the top, and at post-procedure after about 6 hours, that is the echocardiogram. Remarkable difference. I guess this is because we relieved the stenosis, but to get to that position, we needed hemodynamic stability in a cardiac shock patient, and that's why ECMO was used. And of course, the case was published also. What about emergency situation? Because sometimes we will get called for an emergency outside our unit, and that unit may not have a cardiac facility, but you need to retrieve the patient. I'll give you an example. This is a 65-year-old man, EF 15% with cigarette stenosis, had multiple VT arrests in a non-cardiac center and was inotropic dependent. And what do you do? So we received the call, we went there with our unit, and this is him. You can see here on the picture. Of course, the pictures were not taken intentionally. They were taken by a perfusionist. We used it for education purposes. He was not intubated. There was no anesthetist in that hospital, but he was in a HDU setup. So under percutaneous guidance, we went on VA ECMO, but straight away, the patient was on pump support. As a result, no matter any number of cardiac arrests, you don't need to resuscitate because you've got aortic stenosis. Whatever CPR you do, it's unlikely you're going to get stroke volume out. And because you have cardiopulmonary support, you can just shift the patient safely for further treatment. Of course, the patient was shifted to our unit. Of course, we changed the valve, did multi-vessel revascularization, and were discharged after an ordeal of 10 days. But they actually do well, and that's because of the pump support that you give in the initial period. This is him. After 5 years, he's practicing as an auditor. I hope you can recognize his face. Look at that face 5 years before. The same guy. Very, very gratifying when machine comes to help. What is the protocol in my unit? This is what I do. I have 3 strategies based on how sick the patient is. Strategy 1 is the patient where you think they may end up on ECMO. So therefore, you don't want upfront pump support. You don't want to spend money. You don't want unnecessary extracorporeal circulation and cardiac response. So what do we do for them? I put a venous line and an arterial line, and that's it. We just sit tight. If needed, we can just quickly go on VA ECMO in literally 2 minutes. That's it. Strategy 2, these are patients slightly more sicker, but I really don't want to get an arterial cannula because peripheral vessels are bad. Then I obviously will get a venous cannula, no harm, it's 21 French, clamp it and wait. And if the patient crashes, then you can put a large bore arterial cannula and then you can go on the pump. Strategy 3 are the obvious, really sick ones. You know you're going to have trouble. We go up front, ECMO. So you start on ECMO and you finish, come off ECMO. Once your intervention is done, be it VT ablation or a structural intervention or coronary intervention. Coronary intervention, of course, bread and butter for all of us. This is a case, I'll give you an example. He's a doctor and he had cardiogenic shock, presented with this anatomy. You can see here, critical left main going into LAD and circumflex, and therefore we used ECMO and IABP, ECMO for pump support, IABP to offload, and obviously angioplasty was fairly straightforward. We can angioplasty, but this is feasible and safe with a complete pump support. I know I'm going to get him out and I'm not going to be running around with hemodynamic instability because the patient is stable with steady state blood pressure. And you can see here pre, above, and post, below, achieving good outcomes where you don't have to rush, because when your hemodynamics are sorted, you can optimize your PCI, take your time, and get the best outcome for the patient. This is just to give you a feel. That's what they start with on top with just cannulas, and when we finish, it's all done, as you can see on the bottom. They are percutaneously closed. We don't leave any cannula. Everything is checked with DSA, and they're out from the cath lab, and you have peace of mind that you don't have a vascular problem. And of course, not just equipment, you need space. It's very, very important you have enough space to be able to handle all this equipment and teams. So to conclude, awareness of the apt hemodynamic requirement is crucial. Upfront preparation, being prepared, is also crucial. Space, logistics is important for long-term success. And last but not the least, the teams, very important. And start early than late. That's something I've learned from my own mistakes. So if you think about it, you might as well start it rather than involve later. And of course, have a good heart team, which I think I couldn't stress more. And for those of you who might want to learn ECMO, there is, as far as I know, there's only one dedicated ECMO course for cardiologists. This is run by Sun Pharma. I thought I should put this forward. You need to contact your Sun local representative. This is run in Mumbai, where it's an animal lab. You put ECMOs in animals, and then in mannequins, you learn everything about ECMOs, and that allows a certification by the Royal College of Surgeons towards helping you in your clinical practice with ECMO. And this is dedicated for cardiologists. Thank you, ladies and gentlemen. Questions.
Gopal, it was a wonderful presentation, masterly one. During cardiogenic shock or during a CHIP PCI, during a cardiogenic shock ECMO, you always would want to have a 19 French cannula for the arterial side. Now, for a CHIP PCI, would you want to go in with a 14 or a 16 French arterial cannula, hoping that you wouldn't need a 4 liters output, probably 2.53 would be fair enough just to support the heart, or would you still go in for a 19 cannula? Because primarily the problem that you encounter with a 19 cannula would be you would have increased bleeding chances. So would you downsize it if at all you prefer it for a CHIP PCI?
Yeah, CHIP PCI, very rightly asked. For a 70 kilogram man, I don't need any more than 16 OD. So it should be fine. And the 16 is, we're all familiar with 16 French. So 16 arterial is plenty. It will easily give you 3 liters, and that's all.
In our hospital, the ECMO program is run by ICU, and a month ago, Prince Charles did the Australian, New Zealand 2-day course on ECMO. We have not initiated in my last 5 years in the hospital ECMO in the cath lab ourselves. Usually it's done by ICU, and we're looking forward to expand it to cath lab. My question to you, in the cases that you showed, mainly in those cheap, high-risk procedures, the left main cases. If you had unlimited access to Impella CP in those cases, would you use Impella instead of ECMO, or ECMO would be your still first choice?
No, absolutely. We have Impella also, so we use Impella. The main problem is cost, and cost is a big problem. But if they're coming in with shock, with respiratory failure, pulmonary edema, where oxygenation is a problem also, I would go on VA ECMO and IABP. So I know the substrate. If the substrate is going to be a quick left main, I know if you get on VA ECMO, which is cheap, an IABP to offload, and once the vessel is open, they get quick stability. We don't need to rush in for an Impella. But of course, if the problem is an isolated LV problem and the patient can afford, then yes, Impella is my preferred, and that's something we do also.
Yeah, yeah, Dr. Gopalamurugan, this is regarding the catheter size. See, at our place, the ECMO is run by the anesthetist, and I have been informed that they can't put anything less than a 19 French inside. So I'm a little pretty surprised when you said 16. So with the 16, how much liters do you think 16 will give?
3.5 liters.
For us?
3.5 liters, easily.
3.5 liters you can get with 16?
Yes.
Okay.
For a 70 kilogram person, I think that should be plenty. But of course, if you have a larger person, then you might want to put a larger cannula. You will obviously put a larger venous cannula, no matter what the weight is for an adult. So you'll have good outflow.
Which cannula is this? A 16 French cannula? Just for information.
Medtronic.
Medtronic. Thank you.
So we have few cases done with cardiogenic shock as well as acute MI intervention with ECMO. In all our situations, we have put in 19 cannulas,
19, yeah, that's what I
except
was
in one situation where we didn't have an arterial access. We had to go through the subclavian artery to percutaneously puncture. We had a 14 cannula. With a 14 cannula, we were able to achieve flows of about 2.7, 2.8.
But I think the problem, when you said right now, I also realized is the reason we are also using 19 is, and you're also using 19 is, because I think there was both our technicians came from the same school. So they are using only 19.
Again, moreover, with 14 and 16, you tend to have more of hemolysis and chattering. Things like that could happen with lower size cannulas.
I think it's largely down to the comfort of the perfusing teams and the size of the vessel you have and the expertise in closing large bore access. So if you have a good caliber vessel and your team would like a 19 and vascular closure, something doing routinely, going 19 is not terribly different from a 16 OD. We should still be able to get this out of thought.
Are there any more questions, or we move on to the next presentation? Gopalamurugan, thank you very much for joining us despite having challenges at home. Thank you very much for being with us.